following program contains graphic scenes of surgical operations, which may be disturbing to some viewers.
Ever since man rose up on two legs, he has wanted to see who could run the fastest or jump the highest. Sports are as old as humanity itself. But these games are more than a test of the human spirit. They're serious business. And increasingly, staying in the game requires 21st century medicine. New surgeries save careers. Scientists use the power of the computer to prevent injuries. Human bodies are fine-tuned like machines to extract every ounce of performance. And sometimes, sports medicine isn't about getting an athlete back on the field. It's about saving his life. Sports medicine is making amazing strides to get athletes back in the game. It's moments like these that Rob Stevens lives for.
This is what it's all about. This is the environment that makes me tick.
Rob has been skiing since he was old enough to walk, but 40 years of wear and tear and a recent injury have taken their toll. His knees ache with every turn. So this is Rob's last run of the year. Already, his right knee is starting to swell.
So it's a little sore than when we started this morning, and it's kind of reinforcing my decision to make this move. When the sun's out and we're expecting 4 to 6 inches of snow tonight in Vail, tomorrow would be a good day to be skiing as opposed to visiting with Dr. Stedman on the operating table.
Rob has come to Vail, Colorado for two reasons: to get in one last day of skiing and to see Dr. Richard Stedman, one of the top knee surgeons in the country.
Okay, just point to where you feel it when you ski.
Yeah, every time I ski hard and tough terrain, it swells up and gets unstable.
Okay, let's just see this knee first, straighten it out.
Dr. Stedman believes Rob has torn the cartilage in his right knee. He'll repair it arthroscopically, using a tube-like camera. But he may do more. He may try a procedure that's revolutionizing knee surgery, a procedure that will actually grow new knee cartilage.
So our plan would be to try to make some cartilage form on the area that's lost its cartilage cap.
Before he can fix Rob's knee, Dr. Stedman has to look inside it. But finding torn cartilage isn't easy. Dr. Stedman has been reading MRIs since they were invented 17 years ago. And even for him, they can be hard to decipher.
If someone walks in with an MRI, I mean, it's 60 images, and I'm seeing 40 patients that day, and it's hard to take the time to look at 60 images. So if you have a computer system that takes the MRI, creates a virtual knee, and you can look at the knee, it's good for you and good for the patient.
Just help visualize a little.
So scientists at the Stedman Hawkins Clinic are developing a new tool that will make finding injuries easier and more precise. It's called the virtual knee.
Right now, physicians are somewhat limited to a 2D plane, but when you look at a 3D model, it really gives you a much more precise idea and geographical orientation of what's happening inside a knee joint.
The day before his surgery, Dr. Torrey asked Rob if he could record his movements to test the virtual knee.
The cameras collect a view of the markers. The software then integrates each of the 5 camera views into one 3-dimensional view. And so Henry and Mike here are digitizing your data, getting a 3-dimensional view of the motions. This essentially represents the motions of your skeleton as you're going through your activities. So once we have this information, we'll then apply it to the 3-dimensional knee model, and we'll really be able to see where things are rubbing.
These moving images, along with Rob's MRIs, are fed into the computer. The result is an exact 3D image of Rob's knee. The virtual knee will show a defect no matter where it is. It's seen here, highlighted in blue.
When Rob had his injury skiing, he probably was in a very flexed position, and those two bones, the tibia and femur, collided with each other and essentially knocked out that area of blue.
So he's got bone rubbing on bone in that when he's flexed enough that this piece of where used to be cartilage is in contact then with the tibia.
The virtual knee is built around a simple yet vital concept. Every knee is different.
Every person who walks into Dr. Stedman's office or any physician's office is a unique case. And so their joint is unique in its own right. And so it's time to start studying these joints on an individual patient-specific basis.
And the virtual knee will let a surgeon do something he could never do to an actual knee. Try several different procedures before deciding which one to actually perform on the patient.
Let's say the surgeon wants to take a ligament away from the knee and maybe place the ligament in a different orientation. And everything else remains the same, so the computer can sift through what would be the effect of that simple surgery procedure. And it really allows us to do any what if and really provide the doctor with an in-the-knee perspective of what this knee is doing in a dynamic situation. Rob can tell us he's in pain in this deep knee flexion, so we get to actually see it because we can't see inside his knee.
Dr. Torrey's virtual knee is a year away from completion. Dr. Stedman looks forward to a time when he'll have the virtual knee pictures in surgery. He could have used them today. Rob's injury is in a difficult place to reach.
We still can't see all the way back yet. So you can see this area here is articular cartilage. This is a hole in it. These little kind of bumpy pieces here are irregular bone, which would normally be quite regular.
In years past, the hole in Rob's knee cartilage would have led to painful arthritis that could have put an end to his skiing. The problem of repairing cartilage has plagued doctors for years. There are short fixes, but no permanent solutions. Now, Dr. Stedman and his team are hoping to convince the body to grow its own cartilage through a new procedure called microfracture.
So you can see the rest of the joint looks fine except for that one area. So it's actually a great one for a microfracture.
Using what amounts to a hammer and chisel, Dr. Stedman will poke tiny holes in the bone just below Rob's knee, causing it to bleed.
So we're just kind of fracturing the bone and have made the body think that this is a fresh injury that just happened today. And so the bleeding that we get back from here is marrow bleeding.
Blood from bone marrow contains two things other blood doesn't: stem cells and growth factors.
The marrow is a great source of these cells, and it tends to form like a marrow clot in this area.
If Rob's knee reacts the way Dr. Stedman hopes it will, this clot will become knee cartilage.
It actually is pretty good cartilage, as it turns out. And through MRI, we can follow the progress of the cartilage, and it's still there and still working. We're actually finished now. We're going to look at the blood coming out of the bone now. And now this blood brings the cells and the factors that we're after. So it went fine. It was a good candidate. You're a good case to do it on. Everything was good, yeah. I think it's really a combination of the last few million years of evolution and us figuring out ways to take advantage of the body's healing properties. So although the possibility for forming the cartilage was there until we figured out a way to get the stem cells in the right place, the growth factors in the right place, and the right rehabilitation to encourage it to become cartilage and not bone or something else. That's the 21st century side.
If the tiny wounds Dr. Stedman created during surgery are to become new cartilage, Rob will have to start rehabilitating his knee immediately.
And we've learned from our previous mistakes in orthopedics that the faster we remove them, the faster that they get better. Doing awesome.
This microfracture procedure, the rehab is really important because you're trying to make tissue grow out of a hole. And so you need to have protection, but if you don't stimulate the collagen until it's supposed to become something firm, then it doesn't work out.
Good.
We think that the mechanical environment that they're placed in is what encourages them to become cartilage cells.
Even when Rob's on his back, his knee is still moving, thanks to a contraption called a constant passive motion machine. For the next 8 weeks, the CPM will keep Rob's knee moving and keep it from developing scar tissue. It's an important part of a long recovery.
From what I've understood, the operation, the procedure was 50% of what you need to do, and the other 50% is the physical therapy and sticking to the investment I'll make to get back out on the slopes. See one of my favorite bump runs right from here.
And skiing is a great way to enjoy the mountains. I want to be able to do that into my 80s, so hopefully this will be a step in the right direction for that.